Good evening, ladies and gentlemen. My name's Kate Loxton. I'm Chair of the SNPHN Limited. It gives me great pleasure to welcome you to our special event, Navigating the New World, Preparedness, Response, Resilience. I'd firstly like to invite Yvonne Weldon, Chair of the Metropolitan Local Aboriginal Land Council, to give the welcome to country. Yvonne, if you'd like to come forward.
Good evening, sisters and brothers. As was said, my name is Yvonne Weldon. I'm a Wiradjuri woman from Cowra, here in New South Wales. I'm from the waters of the Clare, which is also known as the Lachlan, and of the Murrumbidgee Rivers. I am the elected chairperson of the Metropolitan Local Aboriginal Land Council, who are the culture authority under the Aboriginal Land Rights Act for the land that we are on. I'd like to pay my respects to all elders past and present, to you and the many lands that the people online are on. The boundaries of the traditional owners are not defined by the hand or by the pen, but through the natural landscapes of the earth. The Eora Nation's country covers the Hawkes River in the north, the Nepean in the west, and the Georges River in the south. My people have practiced our traditions for thousands of years and endless generation. One tradition is shared in various forms across Australia is a welcome to country. It is more than just words, it is a spiritual process by honouring their ancestors' footsteps we are all walking in, continuing the practice of the many generations before us to the many generations to come. My people have been a part of this land for more than 60,000 years. We are the oldest living culture of the world. And on behalf of the Metropolitan Local Aboriginal Land Council, the elders and the members, I welcome everyone to the land of the Cammeraygal. I acknowledge the Cammeraygal people and also the people of the lands that you are, those that are online are on, whose spirits and ancestors will always remain with these lands, our Mother Earth. The First Nations are the most resilient, unique and sustainable people on the planet. For my people to have survived as long as we have, it's been through a continual practice of respect, collaboration, understanding and a willingness to come together. As we're all joined here tonight and those that are online, let us all give respect and honour. Could you all please pause for a moment to remember the many sacrifices that have been made along the way, the ones we will continue to make, and the ones that should never happen. As you connect, learn and share today, tomorrow and beyond, know that everyone's health and well-being is more important than the material things in this world. There are so many factors that can impact on our health. No matter what walks of life we come from, we all need to support each other, bringing out hidden heartaches to share and bringing us all a strength together. The road travelled alone is the longest, hardest road there is. I will join you and you can join me. The greatest gift you can ever give someone is your time. For so many of you working and supporting people with their health, you often take on more than just a role or a job. It stays with you long after clocking off. So whether you're a health worker, a doctor, a board member, admin staff or a nurse, you all play an important role in so many people's lives. This should be recognised, you are recognised, and I thank you. In these times of this pandemic, don't let the social distance make us socially absent. We must maintain physical distancing, but not creating barriers to our social connections. So whether it's through your work, your family or your networks, creating an inclusion, an acceptance and a resilience. All of us together can bring about positive changes to multiple generations. We are in this together. As we ponder over recent times, think about the difference that you are making today that will become the milestones of the future, all our futures. So let us all draw upon my people's spirits as we continue on our journey. May my people's spirits walk with you and guide you as we strive forward for us all. Again, on behalf of the Metropolitan Local Aboriginal Land Council, welcome to Cammeraygal land. This always was, always will be Aboriginal land. Thank you and have a wonderful evening.
Thank you, Yvonne. They were fabulous words. Those words that, respect, collaborate, working together, they really resonate what we're trying to do here at Sydney North Primary Health Network. Thank you very, very much. Wow, that's great. Okay, now moving on to another really great part of the evening, and that's one where I get the opportunity to thank our sponsors for the evening. Without our sponsors, we can't put on this sort of an event. And so it really is with great gratitude that we thank our platinum sponsors, AbbVie and Amgen. Thank you very much. Our gold sponsor, Genia, I think that's how I say it, Genia Fertility. Thank you very much. And our silver sponsors, Genesis Care and New South Wales Health Pathology. Again, thank you very much. Okay, now I get a chance to go and sit down there, and I'm going to hand over to Dr. Norman Swan. If you didn't know Dr. Norman Swan before COVID, you're bound to know of him now. You will recognise his voice. He is a well-known, eminent ABC broadcaster and physician. He has been helping the whole of the country make sense of this COVID-19 pandemic on both ABC television and radio in recent years, and now here at our symposium. Thank you, Dr. Norman Swan.
Thanks, Kate. And I'll introduce our panel to you. Panelists, there's the clicker if you need it. I hate that technology. So thank you very much. It's not the first time I've spoken at Sydney North PHN, Sydney North Health Network. And I remember, some of you have been there, I was trying to remember, when you were a medical local, I think we had a session on pandemics, didn't we? Or biosecurity, something like that. It must have been about 5 or 6 years ago. And with great interest, I thought, why the hell are we talking about this? Well, I must congratulate you. Electing 2 directors and no court challenges. We're not going to go to the High Court as a result of Stephen getting re-elected. May I congratulate you on that? May the, we just can only, sympathise with our American cousins. And I too wish to acknowledge country and elders past, elders present, and of course emerging elders. And I'd also like to pay respect to Harry Nespelin, who was just a giant of an advocate for primary health care, for general practice, unrelenting, strong person with courage. And I just have to say, I was commenting on this the other day, is that courage is in short supply. People talk, and then when the going gets rough, they run away. Harry never ran away from a fight, but the fight was always for something good. And I wish him and his family a long life. So it's been a year. What a year. Just about a year ago, there was one person in the whole wide world with COVID-19, with what we come to know as the COVID-19 virus, or SARS-CoV-2. One person. What are we now? We're at 33, 34 million people worldwide. Hundreds of thousands, if not millions of deaths. It has ravaged the world, ravaged economies. And those of us who followed pandemics were not surprised. But unfortunately, the way it has unfurled has been preventable. There's not a single textbook of epidemiology or public health that will have to be rewritten as a result of COVID-19. It's followed the textbooks. Trouble is, some of the people in power haven't read the textbooks, and some of the people advising them thought they read the textbooks, but the textbooks they read were in 1940, where they believe this is just droplet spread. But we've done well. We've done incredibly well, and you've done well, because you've managed this in primary care. Because one of the failures early on was that you lot were ignored. GPs, the primary health system was ignored in the panic moving forward, and people forgot that you were the cornerstone of the system. But of course, that's what's panned out. And when a vaccine comes along, you're going to be having your shoulder to the wheels big time as well, when we have probably the biggest immunization campaign in the shortest space of time the world has known. And PHNs and members of PHNs, general practitioners, pharmacists, and others are going to be heavily involved in administering the COVID-19 vaccine, and there will be a COVID-19 vaccine. I'll talk about that in a minute. It has been a truly amazing experience going through this. We still don't know where the virus came from, and we will probably never know that because the Chinese are obstructing the independent commission from WHO from investigating and insisting that the Chinese lead that. WHO, when they went in on an investigating mission, which should have actually gone into the wet market in Wuhan and done proper testing, was not allowed in, and they whitewashed in the early stages. The World Health Organization's got a lot to answer for. Not that I take Donald Trump's side on this. It's an important bilateral or multilateral organization which needs to survive, but unfortunately they've been too weak with China. And as a result, we will never know where this came from. If the Chinese had responded quickly, transparently, allowed external people in late December, early January, it's quite likely this would not have spread globally. But it has. It knows no borders. It's highly contagious. Its secondary attack rate can be anything up to 70 or 80%, meaning that if you're in the right kind of environment or the wrong kind of environment, it can infect 70 or 80% of the people there. In households, it's about 20%. The effective reproduction number is pretty pointless because that's an average. The man who arrived from Victoria and went to the Crossroads Hotel probably had a reproduction number of 15. In parts of New York City, it was probably 6 or 7. But it is a highly contagious virus. And it had a very significant mortality rate, at least at the beginning, and still does to some extent, although we've got better at treating it. And also we've changed our behavior. So I can go over the history here, but I think the main message here is something that we forget. And we certainly forget it when we're in the health professions, but not in primary healthcare, I have to say. It's that pandemics are a conjunction of circumstances. Biology is the least of it. So you get this, bats are throwing off new viruses all the time. But when you've got the conjunction of circumstances, it's human behavior, it's how we live, it's how we have changed the environment that actually create pandemics. And they've done that throughout human history. And they will continue to do that. This virus has no mind, it has no cognizance of any, it's not a sentient being, it's just a little lump of RNA, and it's programmed for survival. And it's exquisitely programmed for survival. It doesn't kill too many people, it's quite contagious, and has actually evolved to be being even more contagious. So as we've socially distanced ourselves, mutants of the virus have actually got round social distancing, and so the virus that we have in Australia today is much more contagious than the Wuhan virus was back in January, but thankfully, no more dangerous. But I think the lesson is, and because you are much closer to the ground, you'll understand that, the front line, is just how pandemics arise. And when we forget it at our peril. So let me just run through. The classic pandemic microorganism is plague, Yersinia pestis, the Black Death. There have been 3 pandemics of plague in human history. The first was in the 7th century, the Justinian plague. The second was what we call the Black Death, which started in the 14th century and lasted for 300 years. And by the way, in the third pandemic, started in the late 19th century in China, and we're still in the third pandemic now. You don't realize it, but we are. So the Black Death is the classic example of, so Yersinia pestis is not a virus, it's a bacterium, lives in ground rodents in Central Asia. They live quite happily with each other. And then usually when there's an environmental disruption, there's a mutation in the Yersinia pestis and it becomes more virulent and more infectious. Kills the rodents that it was parasite, had a parasitic relationship with, and jumps to other animals and then jumps to humans. And in the 14th century, you had active trade routes across Asia, and they took the Black Death to Crimea, where there was a war on, where the Tatars were laying siege. And the plague took off at in this Crimean War and got onto the ships, and the ships took it back to Venice and Genoa, and from there it escaped into Europe. And 25, 30, or 40% of the European population died in the subsequent years. If you read Daniel Defoe's Journal of the Plague Year, it reads like COVID-19. Florence, which many of you visited, had walls around it which they used for quarantine and isolation. People were cruelly isolated in their homes. People didn't know about germs and what caused them, but they had the sense of miasma, so they wore masks. And into the masks they put scent. That's where eau de cologne was started. Eau de cologne comes from the scent that you put in the nose of the mask to cover the stench of people dying. And pandemics affect the poor more than the rich. It unfailingly happens. This is why you don't have to rewrite any textbook, why there was no surprises with COVID-19. People used to say to me, how come you know about this before it happens? Because that's what, you just read a textbook and you know what's going to happen next. So the effect of plague in the Black Death was enormous. It was the end of serfdom, the beginning of wage labor. It was the beginning of the Renaissance, and it ended, and the Reformation. You can trace the beginnings of the Reformation to that. There was an enormous and cataclysmic change. The third pandemic of plague, by the way, it's just so that you know, when you thought it was safe to go out, started in China in the late 19th century. Again, floods, environmental disruption, social disruption through colonialism, and it spread from China by ship around the Pacific. It came to Sydney. There was plague in Sydney. It came under control eventually. What never happened in Australia was that the plague never became endemic in our wild animal population, but it did in the United States. So they had plague in San Francisco, in Los Angeles, and so on, and for some biological reason, Yersinia pestis went into those animals. And every year, people die of plague in the United States, not in large numbers. But here's the conjunction of circumstances that could create another plague, perhaps epidemic, if not a pandemic, is that for those of you who've landed at San Francisco Airport, you'll notice you land along the water, and on your left, inland anyway, there's a mountain, a little mountain called San Bruno. Plague is endemic in the animals on San Bruno. So here's the scenario. There's an earthquake along the San Andreas Fault, causes a mutation in Yersinia pestis, as has happened throughout centuries. It then jumps to other animals, the pet population of San Francisco during a period of social disruption, and it turns into pneumonic plague. And pneumonic plague is passed incredibly quickly by aerosol, funnily enough, and you can die within hours. They'll eventually get it under control, but you could have a very serious outbreak of plague in one of the most sophisticated countries in the world. Syphilis. Syphilis didn't exist in Europe in pre-Columbian times. Almost certainly Columbus brought it back on the ships from Hispaniola. His sailors had no work when they came back, so they became mercenaries to the French who were laying siege to Naples. War is a recurrent story with pandemics. And syphilis broke out. And it was a very vicious disease in those days, still a bad disease, but it was much more vicious in those days. And it broke out. The Italians called it the French disease, and the French called it the Italian pox. And it's been with us ever since, a conjunction of circumstances. We thought when HIV started in the 1980s that this was a new virus. We now know that it's a virus that's been around for over 100 years. And it was a virus that, again, classic conjunction of circumstances, where you've got disruption in the environment, you've got chimps and small monkeys under stress carrying SIV, They exchange viruses. Round about 1920, a new virus is created in chimps who've eaten the flesh of smaller monkeys with different forms of SIV. And effectively, the chimp version of HIV was created and started to spread to humans. And Kinshasa was a central area where people with transport was going in all directions. It did spread, but not very far because it didn't open up. What happened was, as Christianity spread through, as missionaries spread through Africa, they changed the social and sexual mores. So young men found it harder to have sex extramaritally because the missionaries wouldn't let them do it. And you had the growth of the sex trade. You had decolonization, opening up of Africa, international travel, and the rest is history. So the next pandemic could start next week. It could be influenza, unlikely to be influenza because we're socially distancing. But we could have another pandemic at any time, and it could be much more highly fatal, much higher fatality rate than with COVID-19. So the question then is, have we learned the lessons? What are the lessons that we've learned? Well, I hope the lessons we've learned, one of the key lessons we've learned is that community is everything. One of the reasons why the second wave took off in Victoria so badly, apart from the fact that they don't have a health service fit for purpose, they didn't have distributed public health networks like we do in New South Wales and we have in Queensland. Putting that aside, but it's not putting it aside entirely, is that they had no history of serious engagement with their communities. And when the virus started spreading amongst poor and disadvantaged people through that northwest corridor with overcrowded public housing, the Victorian government had no way of actually engaging with those communities to get them to adhere to social distancing and actually comply with what was needed to control the pandemic, and it went out of control. No pandemic has ever been controlled by government fiat. It's controlled by community engagement. When Ebola was spreading in Liberia, people ran scared. They hid people who were suffering from Ebola. They wouldn't come out because they feared the government and they feared the consequences and made the epidemic worse. It was only when the community was engaged and they learned trust that Ebola came under control. So these are the jobs of PHNs. Community engagement, understanding where you are, having a sense of place. I mean, the other problem actually in Victoria are the PHNs, not their fault, but for some reason the PHNs, there's a completely nutty way that they designed the PHNs in terms of geography. So you don't have hospitals looking after populations, and you actually don't really have PHNs looking after populations because they're all over the shop. And that is a serious issue there. So conjunction of circumstances is always where it plays out. And aged care. You're going to hear about COVID and aged care from Sue Curl in a minute or two. Massive failure by the federal government. Massive failure, where they did not learn. They had months to learn, and they did not respond. They had plans before them, and the Aged Care Safety and Quality Commission, which is supposed to deal with these things, ignored those plans, did nothing, and we had a system that was just waiting for a disaster to happen. These things don't happen because you've got some little private operator who's nasty and horrible and out for profit. Yeah, there might be some of them around. The system is what failed us with aged care, and we have to learn from that. The great triumphs, though, are that the community has pulled together. Australia has done an amazing job. We have almost zero spread now in the entire nation. Won't last forever because we're bringing people in from overseas all the time. We've done amazingly with vaccines, and that was a case study in foresight, where 3 or 4 years ago, CEPI and Gavi, the Global Vaccine Initiative, got together and created a competition to create new vaccine technology platforms. And the competition was a vaccine platform that could create a new vaccine to a new organism within 16 weeks. And if they hadn't done that, we still wouldn't have vaccines. But because they did that, we actually had new technology platforms, mRNA vaccines, the Queensland vaccine with molecular clamp, the Oxford vaccine with the chimpanzee adenovirus, and we will get a vaccine. The first vaccines may not be that great, may only be 50% effective, but we've yet to see that. Better than nothing, and the second round should be even better. So this is amazing, and never in human history has this happened where we'll be able to control it. Treatments, not so great. Yeah, dexamethasone will reduce mortality by 20% in people severely ill. Maybe monoclonal antibodies, we'll see. Convalescent serum doesn't work. Hydroxychloroquine doesn't work, unfortunately, nor does antiretrovirals, HIV antiretrovirals. But we've tried. And Britain has done incredibly badly in a public health sense. They've done incredibly well in terms of randomized controlled trials. And they've had this huge recovery trial, which has basically in real time used the electronic record system in Britain to do a real-time randomized trial with massive numbers of people, which showed very quickly that hydroxychloroquine didn't work, that the antiretrovirals didn't work, but the dexamethasone did. And as a result of that, they've managed to actually change the course of things. Have we learnt that? Are we actually going to rationalize our electronic records? Are we going to get over privacy? Of course we're not. We haven't learnt a thing. We have not learnt a thing. We should be radically transforming our data system. We should be sharing data. We should be getting ready for the next time. And we are not. We're not. There was a moment there where the National Cabinet worked well. Wasn't that great? But it's fallen apart again by with internecine arguments. We actually do have to learn, because we've shown ourselves to be a resilient nation, but that's culturally because of who we are as Australians. And sometimes we're not very well served by our politicians. But I'm carping on because we actually have done well, but hopefully we're ready for the next one. So thank you very much. And we'll take questions later. Let me introduce our panel to you, who are going to talk about the sort of resilience and response that's needed to move forward. Penny Burns, who's a general practitioner, and just want to come up, Penny, when I introduce you. Penny Burns, the general practitioner, and who's got expertise in disaster responses. Sue Curl, who is a geriatrician, area director of geriatric services in Northern Sydney, and professor of geriatric medicine. Pankaj Arora, who is a specialist in emergency medicine, founder of Wise Medical and director of emergency and training at North Shore. And Peter Sainsbury, Professor Peter Sainsbury, who is a public health physician, public health researcher, troublemaker, and luckily for all of us continues to make trouble and has a strong interest in climate change. And we're going to have short presentations from our panelists, and then an open discussion including you. And including you online. So remember, ask a question, make a comment. The thing to do online is not to wait. When you've got a question to ask or a comment, do it now so that I can see it on the screen here and I'll bring it in. Don't wait for me to do it right at the end, because the end might come faster than you think. That's great. So, Penny.
Thank you, Norman, and some great words coming out there. I particularly want to acknowledge tonight our First Nations people and the fact that they've been looking after our wonderful continent for the last 65,000 plus years. And as those beautiful words from Yvonne around the resilience and lessons they've learned in managing disasters and coming together as a group. So I've been in disaster management meetings all day, which I just love. And we've been talking there about all the disasters that have occurred in the last year. And one of the managers there got up and he said, in the last year, we've had the number of emergencies we would expect in 2 decades, all rammed into one, and he reeled them all off. Disasters are really powerful, extraordinary events that really challenge our ability to cope. And this is the words of a young patient of ours from the clinic where I work, around the COVID restrictions. I remember when I could go to the park to play. Disasters have a huge effect on our environment. Some of the bushfires recently have changed that landscape, and people are immersed in that environment, and they're waking up every morning to see those changes and feel the effects from seeing those burnt sticks out the window. They change our sense of safety about our home and about our world. Disasters occur, and no community is exempt. They're increasing. So this graph here, I don't know if I can point it out, shows you over the last century, the increase in both the number of disasters that have occurred and the numbers of people affected. They're also becoming more severe, and the majority of disasters are about climate, about 90%. Sydney North Health Network has had not a huge sort of catastrophic defining event yet, but it's had plenty of emergencies over the last year. We've had the Narrabeen floods where there are thousands of people evacuated. We had the storms, this 10-minute storm that hit on the North Shore and put 52,000 homes and businesses out of power for several weeks. And we were seeing people coming to our practice looking for medications because their general practice was closed. We've had the smoke and the bushfires, and that's travelled for miles and miles and lasted for days and days. And we've also had the heat waves. Our neighbouring PHN set an Australian record for temperature in January and was the highest temperature on Earth for that day. In the emergency planning document that covers this area, apparently bushfires and floods are likely, earthquakes and landslides are possible, but pandemics are actually unlikely, so you can actually relax. When the pandemic actually hit Australia, this PHN was the first hotspot. So I'm very passionate about the health effects of disaster. I admit I'm doing a PhD on this, but the most powerful effect of disasters is on humans, and it's on human health and well-being. And there's a huge amount of research that shows us the effects on health. So we know that there's a huge cardiovascular impact during disasters. There's a condition called broken heart syndrome, Takotsubo's cardiomyopathy, and this was first seen after huge earthquakes in Japan. We since saw that in Brisbane. One woman was caught in flash floods in a spinning car and developed this. And then following the Christchurch earthquakes, we saw 21 cases in the first 2 weeks. This was alongside an increase in myocardial infarction, hypertension, worsening of heart failure, and then strokes in the first few months. We know all this. We also have seen effects on the endocrine system. We know that there's a risk of increased new incident diabetes, and we also know that there's a worsening effect on pre-existing diabetes over the 3 to 6 to 9 months following disasters. There's effects on the respiratory system from dust and smoke storms. And the one that won't be any surprise to any of you is the huge effect on chronic disease. So the true burden of disaster healthcare actually falls in primary care. WHO articulates this. This is the words of an emergency physician in Japan after the Great East Japan earthquake and tsunami. Lots of pictures of the acute response and dramatic savings and dramatic healthcare by the emergency teams, but no one saw any of the huge volume of work that was going on in the evacuation centres and in the community managing chronic disease. And we know that there's a 3 times increase in acute exacerbations in those that have chronic disease. We know that medications are an issue. We know that often medication needs adjusting. And most of Australians do have chronic disease. So I'm going to go back to Norman's idea of a scenario and say, if disaster struck you now, right now in your community, and what would you do? Let's say it's a huge storm, it's a big storm cell, it's come across, it's caused flash flooding. 4 people have actually died in these floods. The power is out to a large percentage of businesses, general practices, pharmacies, and homes. Roads are cut off, the hospitals are full, people can't be sent home because their homes are flooded. What would you do? This is actually a scenario that occurred a few years ago up just 2 hours north of us in the Hunter region. So it's not an unrealistic scenario. I want to take you just very quickly through 3 examples from Australia and our colleagues in New Zealand of how GPs have adapted and responded when disasters struck their community. Oops, sorry. So the first one is, So the first one's the Brisbane floods in 2011. So this was a community that was separated overnight by flooding and cut off. They had their shopping centre, their general practices, their pharmacies were all flooded, and this GP set up in a church and started working and seeing patients, thinking he'd be just doing that for the day. 3 days later, he was still seeing patients, and some of them were being evacuated and flown out by helicopter. There are also some of the GPs wading through water trying to access those who are more isolated. In this one, in the Victorian bushfires in 2009, huge effect on this community that's shown here. There were 50 people killed within the space of an hour, and 50 people's homes were sort of burnt. It was a horrendous event. We had GPs turning up to ovals with their doctor's bag and nothing else to help the community. And then this one up the top, we had some GPs attend and work in these tents that were supplied by ambulance for several weeks to try and help continue that community healthcare within that community. And then after that, for months, we had GPs working in these demountables that were not very comfortable. They were cold and they had paper stuck on the window for the curtains, trying to service those communities. And this was just actually as the 2009 pandemic was striking. And then the third one is the lessons from Christchurch. And we've learned a lot about disasters from our colleagues in Christchurch. So this occurred in 2011, and the response of general practice there was phenomenal. They really stepped up. In all parts of the city, they stepped up and started seeing patients. And this pit here is in the centre of Christchurch, where one of the practices set up in a car park, and they saw hundreds of people coming through. They were working really tightly with ED. So ED was overwhelmed. They had people flooding in. But the ambulances were bringing the triage levels 3, 4 and 5 into this practice that had to step outside because everything had been shaken off the walls, they had flooding, they had dirt coming up and it wasn't safe in their building. Yet they pulled together and they managed to help with the overall healthcare response. Sorry, there's a delay. So what are the lessons learnt from these GPs? There's 2 lessons I'd like to leave you with. One is the importance of general practice in maintaining that continuity of care. It's a really, really vital role and it takes the load off the EDs and the hospitals. GPs are best placed to be in their practice. That's where community will look for you. That's where you're best placed to have the best resources. You've got your team there. You're also best placed to be able to extend your hours and see some of the first responders, extra people who may need assistance, and you're best placed to be able to manage chronic care and manage those change in medical conditions that will occur. This here is a graph around the change in resilience, if you like, following a disaster. So there are communities that have really pulled together really beautifully following disasters and worked together, and they've created a new norm, and some of them have created a very, very good place, a very strong community that's stronger than it was before. Others who have been through similar disasters have not come together as well and have created lesser trajectories afterwards and are still recovering. Community is really powerful, and coming together as a community to respond to these things can really make a difference in outcomes. And the second lesson that we learnt, was about being prepared. So this is a note here from Christchurch, and they were listing the good things that happened following the earthquake, the things they did well, and the first thing on the top of that list is we had a plan. So the second lesson is it's really, really important to sit down and have a plan. Sit down and do a rough and dirty one-page plan with your practice, with your allied health teams, with your community healthcare groups, and just have that plan. Just do it one page, and then when something happens, you've actually got something to work off. And I think it's really, really important that primary healthcare steps up to the mark and make sure that they're a strong part of any response in these events, as we've shown during COVID. And I think the one thing that we do know is we don't have the power to know when a disaster is going to strike, and we don't have the power to know what type of disaster it's going to be, but we do have the power to be prepared. Thanks.
Thanks, Penny. And our next speaker is Sue Curl, who's going to talk to us about aged care and COVID. And Sue's part-time job in the last few months, I say part-time in inverted commas, has been as medical advisor to the Aged Care Royal Commission.
Thanks, Norman. Hi, everyone. See if we get it working. Okay, so I'm going to take a sort of similar track to Penny. I actually do more clinic work down the south coast of New South Wales than I do in Sydney. My other jobs keep me up here, but I actually work down there quite a lot, and I was there right through the bushfires. In fact, our little house was saved by about 250 metres of space because the wind changed, and we were just incredibly lucky. And we live really on the only almost non-burnt part of the south coast. But there's some photos. Actually, the one on the left is South Durras, where I am. It's a very old area, the south coast, which is why I'm there. We're just trying to get more geriatricians down there. I'm virtually the only one south of Wollongong, so it's fairly busy. But it's interesting, its main services, its main industries are human services because it's a retirement area. It's full of old people. The median age is 52, so there's a lot of old surfers, I can tell you. But 35% of the population in a lot of the area is over 65. It was the Currawong fire that started, and it started back in November up in the Budawangs and just moved gradually south. And we watched and we thought, oh no, it's not going to come. It worked its way down. It hit north of Bateman's Bay back in mid-December, and then it came through on New Year's Eve. And it was very interesting. There was lots of smoke for about 3 weeks before that, but it actually came through Bateman's Bay and we were not prepared. It burnt down many houses, including several GPs' homes who literally got out in the clothes that they were wearing at the time. Lots of evacuations, including aged care facilities. But the big thing, and this is the thing that is definitely covered, is the power went out. And if you don't have power, you don't have any telecommunications, because all our towers, our NBN tower, our Telstra tower, our Optus tower, Vodafone tower, all had were electric powered. And as soon as the power went out, we lost everything. And when there's no smoke, you have no idea what's happening. It took a few of us a while to realise your car radio is actually a really good place to find out what's happening. But that was the only way. And the roads were blocked, so you couldn't even drive into Bateman's Bay to find out what was happening. And I think for us, it was the loss of power because it took so much. Think whether you could work if you didn't have power. So how did older people cope? And this is what they had to cope with. These are all pictures at the time, the evacuation centres. The good thing was a lot of older people had caravans or motorhomes, so they went and parked those in the right place. The picture in the middle, in the centre, is actually the firemen looking out from the balcony of an aged care facility where they just got everybody, all 90 residents, into the concrete centre and just put hoses, 4 trucks, put hoses onto the facility itself and all around it. And amazingly, it was saved. It was quite incredible. The bottom one is, I think that's the Catalina Country Club that opened the whole club area, a bit like this actually, similar carpet probably, to older people. But the other place was on the beach, and I have a number of colleagues who've got photos. In fact, one of these is one of theirs. And they said they're on Lilly-Pilly boat ramp and there were goats and chooks and sheep and cats and dogs and people. And they all were happy together in the smoke, and the fire literally came down right to the water. It was incredibly terrifying, and I think Andrew Constance was a good example of how it affected quite a few people. He lives right next door to the nurse I work with down there, and she lost her back fence. He didn't lose his, but he was pretty lucky. But it was quite amazing because we were there, so we offered to do more work, and we did. And I was just amazed. Old people coped incredibly well. I will use the word amazingly, I realise, quite often in this, because they amazed me at how they did. I thought we'd be doing lots of helping. They were doing the helping. They were babysitting for younger families. And it was just gorgeous. They would say things like, oh, we've seen worse than this. We've lived through other fires. And the one thing I heard often was, this too will pass, which is biblical, but I can't exactly find where from. And they said, no, we've lived through worse than this. And I heard a few times, it's nothing like the London Blitz, or a little more locally, it's not as bad as Darwin in World War II. And most of them would say things like, oh, I'm fine. There's lots of people worse off than I am. And they did find the evacuation centres hard, sleeping on the floors. And if you've got nocturia and you've got to climb up from cushions on a floor and find the loo in the middle of the night, it's pretty darn hard. But people pulled together really well. And I would reflect really what Penny said. The GPs were amazing. Even the one who lost her house, they were all down there at the evacuation centre with their bags, with their script pads. The pharmacies opened even though they didn't have electricity, and people couldn't pay because, of course, most of it's EFTPOS these days. I tell you what, always keep cash. Cash was absolutely king. Our local petrol station had a generator, so we could get petrol, but you couldn't pay for it unless you had cash. Neighbours were making sure that older people, they went and got them ice and they went and got them food. It was just wonderful. A number of services arranged trailers with laundries and showers, because that's what people really wanted. You can only wash in the ocean so many times. And neighbours with generators, and I have to say, we had a generator. We have two now. We were very popular because you could charge up your phone and your computers, and people would put their generator out on the drive and put big power boards out so people could come along. So this is Bateman's Bay, Moruya, that area. The only losers were people with dementia. They could not cope. Why do I have to leave home? Where are we going? What am I doing every 2 minutes? And they did not cope well in the evacuation centres. And we did have quite a few have to come into hospital. The interesting thing was aged care facilities actually opened their doors, and we kind of did rapid approvals so people could at least be looked after for a while. Why did they cope so well? And I think they're a really good lesson for us. I watched 80-year-olds comforting 40 and 50-year-olds. And I think you'd think it would be the other way around. Well, it wasn't, I can tell you. And we were down there for a month working in these centres. But they would say years of survival, years of living, years of coping. It's the life experience. And they saw the glass as half full, not half empty. And I would say the depressed ones would have been dead by now anyway, because we know if you've got a glass half, that attitude, you're going to live longer. But just two examples of resilience. The oldest home buyer in New South Wales lives in Moruya. And she had her house in Rosedale burnt down to the ground, so she promptly went out and bought a house in Moruya, and I'm told she is the oldest home buyer in New South Wales. 104, that's not bad. She saw that as a wonderful opportunity to change houses. My lovely 89-year-old who came in because she had an appointment with me, she just spent 2 nights in Moruya Showground. She didn't want to go into the evacuation centre because she said it was too noisy and her cat wouldn't like it, so she slept in the car at 89. And she said, I don't know what my great-grandchildren will think, but she did it. And there were lots of stories like that. They were amazing. A lot of people saw the fires as an opportunity. Oh, well, that's all right. Yep, we've lost it before, and we can build again. I thought people would give up and want to go into retirement villages. They were amazing. And what it did was bring the community together. And I've seen that since in my community in Hornsby with COVID. But I think it's got people planning, and they wanted someone in charge. And you may remember the South Coast was where Scott Morrison came to grief. And he certainly wasn't seen as in charge at all. And so there's been a lot of talk about that. Are we prepared? It was interesting. I don't know about you guys. We've got, where I live in Hornsby, we're right on the bush. We have a bushfire plan. We have a group in the street. We all know where our house keys are, who's got pets, where we will meet if there's a fire. It works well. We've done plans. I think certainly I encourage people, and we've joked about this, but I get people to do their power of attorney, their enduring guardianship, maybe an advanced care plan, and I ask them, do they have a fire plan? What would happen if there's a fire? And we started doing that about 2 years ago, partly as a bit of a joke, but I tell you, it's paid off. And certainly down south they did. So many people had fire bags. They had a month's supply of medication. And I would encourage you to say to your patients, always have 3 months of your medication in a bag. It's important. People would have their own bag, their dog bag. It was really rather lovely. And it meant they could respond and get out quickly. So we had recovery, and it's fantastic to see things coming back. Anybody that's driven south, either down the King's Highway or the Princess Highway, will know it's recovering. And we thought we are doing really well, and then along came COVID. Now, it's interesting because a lot of older people's only social outings were shopping and the doctor, and they were the two things we were fortunately sort of able to keep going. But the big thing for us was initially people who were getting care at home stopped. People just panicked and stopped giving that care. We had several cases come into Hornsby of people who were basically half-starved because no one turned up to look after them. No one turned up to shower them or do what they needed. But that's when neighbours actually got in. Telehealth's changed a lot of things. I think it's been really good. Electronic prescribing, which I know has been quite successful here. The face-to-face contact is missing, and it's very much missed. And we only had 2 weeks where we didn't do face-to-face at Hornsby because people started saying, oh no, we know the hospital is quite safe, sort of. It was interesting, My Aged Care did offer services, but any of you that have tried to access My Aged Care would know how hard it is, and they were pretty dreadful at trying to organise things. The community was much, much better. We did quite well down at Bateman's Bay until the Soldiers Club, and we had this amazing group of 8 people. Now, that was a Friday afternoon. On Saturday, all the businesses voluntarily closed. There was no say do this, they did. All the shops closed other than, the supermarkets, the pharmacies had restricted hours. It was absolutely incredible. The whole town pulled together. I've never seen anything quite like it, but it was just brilliant. It was the 2 weeks my husband and I took off thinking we'll have a break from COVID, and we went down and we're right in the middle of it. But everybody was checking on each other. There were 2 further school kids, one at the public school, one at the high school, but that was it. That was the end of it. They, as Norman said, they did what they were told to do. And I can tell you, Norman, if I had $1 for every time I heard your name quoted about what they were doing, even the lady in Aldi told me she heard Dr. Norman Swan say they should close up and socially distance. So your name was used in vain quite a lot. We've gone a little back. I don't know where the rest of the presentation went. I'll just try once more. Oh no, it's gone. I just had one more slide really on COVID, and I did want to talk about COVID in aged care facilities, and maybe people didn't like what it said, so it got cut out. We've done pretty well. You saw what's happened with the aged care facilities. We've been involved in the education. I think what really shamed me, though, was the difference between Dorothy Henderson Lodge, which was our area, and Newmarch House. We took people into hospital. Everybody got involved, including the GPs. In fact, there was one GP that went in, I think, and was there in Dorothy Henderson. Newmarch House, it was just a mess. And I think what worried me most was that people are saying, well, older people from residential care shouldn't come into hospital. Why not? They have exactly the same right as anybody else. And we brought older people into hospital. In fact, we had a number of people from Dorothy Henderson in Hornsby Hospital. Some died, a lot actually got better, and then drove us mad until we could get 3 negative swabs, which they insisted on having before we could send them home. But I think we really have to think what we can do for the future, and I think it really is be prepared, I know that. I think what I said before about encouraging your patients to think about their own personal plans and having their disaster plan ready. As Penny said to all of us, what would you do in your practice if there was a disaster tomorrow? I think we also should be saying to our patients, and we do it as part of, as I said, advanced care planning, where would they go, who would they talk to, who's got their phone numbers, things like that. I really think we need to talk about. Now, there was one more slide that I did want to show you, but that's all right, I can tell you about it. Most of you will know about my interest in exercise, that, you know, if we could put it in a pill, it would be the most effective medication ever marketed. Well, the slide I had was to show you the most cited article this year in JAMA, the Journal of the American Medical Association, was the one that showed the more steps per day you do, the lower your mortality. And it's not related to intensity of steps, so you don't have to step really hard. It's the number of steps that is important. And if you can do more than 12,000 a day, well, you're probably going to live a lot longer. Thank you.
Thank you. So you're all walking home. Pankaj.
Good evening. Thanks, Norman, for setting up the stage for us, and Penny and Sue for such a brilliant presentations. And that sort of brings us together to this evening, when I thought this is a great moment for us to reflect back on the last 8 months of weirdness, what I call it as, which we didn't know what we were doing, believe me or not. And in the first slide, I just do say, I think people are saying resilience and everything, but I think the awareness is the big part of it. And peoples of the likes of Norman have been instrumental in spreading that awareness amongst us into our community, and then after that the community accepts that we are in a problem and we need to deal with it, and then from there we become flexible, we become adaptable, and innovation grows from there. So that's the kind of a natural phenomena which we went through, and I just want to take you through the true journey of how we worked through the Primary Health Network, local primary health network, and were able to be, had the privilege of contributing to the control of this pandemic. Right Respiratory Clinic was an opportunity, and I always say when the things have happened, we sit down, sit back, and we tend to lots of time learn from our mistakes. But I think we should also learn from what we did well, and that actually goes a longer way. And we have heard this word preparation, preparation, preparation. That's the mantra of medicine. Whether you're intubating a patient, whether you're waiting for a trauma, preparation, preparation, preparation is the key. And that's pillars of our disaster medicine and pandemic medicine. And prevention, prevention, prevention. Again, community spread. The role of prevention is at every level. Community level, which is we call it as the primary prevention, at the doctor's level, where we call it secondary prevention, and the hospital level, we call it. We all were working towards this goal, and we did it beautifully. And the interesting part is, what were we actually trying to prevent, and what were we actually trying to prepare for? The virus, as Norman said, is highly contagious. We didn't want to overwhelm our health system, which is in place, and we were preparing for it, and we were preventing it. And Public Health Department of the state did an exclusive job. I've worked in both community, and I get an opportunity to be in a unique position of working in a hospital setting and in a community setting in an acute care medical center, which sort of gave me that insight that actually what we are doing here, contributing here, is actually stopping the overwhelming of our health system. One beautiful statement which I asked one of my colleagues at hospital, saying, what did we do really good? And she came out with a very good statement, which I sort of, she said it in this way: the authority was decentralized to the community level, to the local health district level, to the individual departments. And I think it was actually the leadership which was handed over to the community level, to the GP level, to the individual departments of the hospital, which really worked well, and there was no chaos, we actually thought. So how did this whole journey start? So we were really well prepared we had some strong health system in our state, in our area, especially the North Sydney area. we had a lead time over the rest of the world to know that it is coming. We had initially no community transmission. It was only few overseas cases when we started to hear about COVID in the hospital and saying, hey, what are we going to do? Hey, let's just think about, oh, what are UK friends of yours doing? Oh, they are actually not testing anyone. They're actually just testing people who are, okay, let's start doing that. And then suddenly we get a message from public health, no, test everyone. So there was a confusion of information everywhere. So we had to sort of go through, filter that into our head. And it was at the ground level, we were taking the decisions what we wanted to do. And there was a chaos in information, and it was inconsistent information changing every hour, every day. We're just printing out a form, sticking it somewhere. No, this has changed now. Now let's do it this way. So the adaptability and flexibility of each of the healthcare worker was so important at that time that we sort of said, and it just naturally happened. And then we had lots of problems in the fear of the COVID, whether the PPE will be provided to us, whether we are safe or not safe. How do I convince someone else when I'm not feeling really good about it? So all these were the positives and negatives where we started with. And working in, as I said, in a unique position of working in an emergency department as in a community as well, with a lot of work in last 4 years, which we have done with the primary health network and with the local GPs, it sort of came as an opportunity. I was just sitting, the numbers in the hospital truly were declining. We were at a preparation fatigue. I said, where are these patients? They're all isolated now. Where are they gone? Okay, so so I picked up the phone and actually texted Cynthia, the general manager of Phoenix. I said, can I help in some way? And she said, are you serious? You want to? I said, yes, of course. and she said, 15 minutes later, I get a call from Simon Cottrell from the Department of Health and say, this is what we are doing. This is what we want to do. The conversation was only of 15 minutes, and I got only a couple of hours to decide whether we want to do this innovative idea of respiratory clinic. And the word was said, and the contribution from the community was amazing. Primary Health Network stepped up with the Australian government, obviously providing all the support with Aspen, and Macquarie University Hospital GP clinic was amazing in terms of bringing the GP sort of contribution to this clinic. We were just talking about the contract at the moment, and I saw these demountables being dropped at the back of my clinic. I said, wow, I haven't signed anything yet. What am I doing here? So this work had started. Friday, this call happened. Sunday, the designers were there on the roadside. We stood and we drew some maps and saying, this is how, don't. So within an hour of 20 types of designs, we came up with this design and said, wow, okay, that can happen. So when these demountables happened, I said, okay, so the targets were laid down very narrow. So now I want this clinic started on Wednesday, but we haven't got a staff yet. We need at least 20 doctors to rotate. You can only make one doctor work for 4 hours because being tied in a mask and a PPE, running around, going to this clinic is exhausting. So we can't have doctors working more than 4 hours, nurses. So again, I say community participation was so great. Sydney North Primary Health sent out a message to all the GPs and nurses in the area, and what happened was on Tuesday, we were doing a massive training. About 40 people got trained into PPE training, and the facility was ready within 48 hours, and we had this workforce standing at our doors, so we haven't even given them any contracts. It was just expression of interest on that to start tomorrow. So it was like a feel of a pace of emergency. We're taking decision every moment. The neighbors are knocking at our door. What are you doing here? At a COVID clinic? Oh my God, I'm not coming in. I'm going home. I'm not going to work in this building. So we had to involve the local landlords, send messages to these guys saying, no, we are very safe. We will be the state of art, first in the country. But once they came and saw the facility, they started feeling more comfortable about it. It's just okay, sorry. And GPs, we were so lucky to have such a talented GPs in this clinic and in this community. They not only stepped up, but they actually felt that they were really contributing to the community, that this GP respiratory clinic now was a place where those patients who couldn't be examined in the rooms which were not safe to be examined, now we have provided them with the rooms where the GP can actually triage them, can examine them, have a conversation with them face to face. Those who were doing telehealth, they were able to send the patients here for physical examination. And that sort of became very passionate for the GPs working in the area. And the Sydney Morning Herald article written by Martine, she wrote really beautifully, we were going to keep our tools down if we don't get our PPE, but we are feel so safe here. That's sort of the spirit we wanted to sort of distribute amongst the patient and amongst that we are being provided with whatever we need. And that was I must congratulate the Sydney North Primary Health for giving not even one single day we heard that we don't have a PPE. The flow of the clinic was made in a way that we had 4 rooms. 2 of the rooms were called green and 2 red rooms. The green rooms were for screening the patients and 2 rooms were for the swabbing the patient. It was one-directional clinic. We could only walk in one direction. If you walked that way, you can't return so that you don't face another person, and then you have to take the whole turn of the building. But having said that, the luxury of the space we had next to our clinic was amazing. And if you see these pictures, if we had a boom gate, security became a very big issue before starting. It was very controlled by appointment system done by Hot Doc online. They were given the address. We never advertised the address to everyone. And then there was a medical student team from Macquarie University Hospital came up to be the ushers to guide the patients through. They were also provided with full PPE. They would have a waiting area, was a car park with unregistered patients and registered patients. And that sort of a flow really went well, and every one of us as well as felt very comfortable with the infection control. Also, at times we felt that we don't have some knowledge, and whenever I said that I need backup for an infection control doctor or this thing, and it was looked after. Someone from Canberra would talk to me, someone from locals. I even gave call to some Melbourne infectious disease doctors organized by Primary Health Network. So the whole spirit was so good that I just was overwhelmed with how, with speed, with the community help we could do, build up this respiratory clinic, which was first in Australia within about 48 hours. We have seen up till now 16,600 patients, and we have had only 11 positive cases, which is a good news. And there were only about 40 hospital transfers. 160 patients needed some extra care, but not hospital care, so they came to WISE. And 30% of the patients who came actually required just more than a COVID test, or required more than a temperature or a saturation test. 5.5% were children less than 2 years. They all needed to be examined, diagnosed conditions like pneumonia, tonsillitis, UTI, and even certain cases were really life-saving, where we had diagnosed few PEs and some new cancers through this clinic. So this is just an age distribution of the type of patients which came. And then we did a little bit of a survey on how the community felt about this clinic. After 8 months, the community actually is really happy with the clinic. So it was really positive, not even one poor comment. And the feedback was amazing, and they want this facility to continue. And I think the future of this clinic, respiratory clinic, is still in questions. The numbers have gone up and dropped. How we use them, now we have learned that it can be popped up. We call it as a pop-up clinic within 48 hours. So we have the technical know-how and this thing. And with this such a beautiful network and collaboration we have created, I think this was a very good initiative, and I was very blessed to be a part of it. Thank you so much.
That's fascinating. And finally, Peter Sainsbury on climate change, the environment, and what we need to do next.
Sorry, start. Okay, thank you very much, everybody. Thank you, Norman, previous speakers. I'd like to pay my respects to oppressed people everywhere. Now, I'm going to talk about climate change, which is at one level quite different to COVID, but in actual fact, going back to what Norman was saying, it's the causes are almost exactly the same. It's our complete disregard for the environment and for the way we live and for our use of resources and the way we dispose of our refuse and sewage and one thing and another. It's all the same. One direction gives us climate change, another direction gives us COVID. Now, I'm not going to give a sort of climate change 101 today or climate change and health primer. What I'm going to do is hopefully send you away completely depressed. Because I'm going to tell you that the situation we're in is desperate. We urgently need to take some action. We're not doing anywhere near enough to solve the issue. Well, we can't solve the issue. We're undoubtedly heading to a climate and an environmental catastrophe. That is inevitable. We're probably heading towards a major societal collapse. Okay? All we can do is reduce the impacts and prepare, as we've heard already in different contexts, for those impacts. And whilst the environmental collapse and the societal environmental catastrophe and societal collapse might not happen during most of our lifetimes, if we don't act now, if we haven't made the changes necessary in the next 10 years, then the situation will be just about hopeless for our kids and grandkids. If you think I'm being completely doom and gloom and over the top, then I can only assure you that this is what I genuinely believe on the basis of the evidence. So, I don't want to talk about climate change and health. You can go away and read that. But I do just want to bring this figure to your attention, a figure in the New England Journal of Medicine a year or so ago by Haynes and Ebby, because I think if you're looking for a summary of the effects of climate change on health, then this is a great one. This is the top half of it, where you can see it identifies some issues around the environment and climate change and health. It flows down to sort of exposure pathways, and then the bottom half of it illustrates the various ways in which climate change will affect people's health and the sorts of conditions that emerge. So I just want to bring that to your attention, that's all, so that you can go away and have a look at it if you want. I was going to say a little bit about the effects of climate change on health services. In actual fact, I've got very little to say that hasn't already been said by the three previous speakers. They've illustrated very well that when we have an extreme weather event, it's not just that people are going to flood to us, patients and so on. In fact, they may not flood to us because they can't get there. And that's what's been found in cyclones in New York and New Orleans and one thing and another. They may or they may not. They'll be out there, but they may not be able to get to hospitals and community health centres and GPs and one thing and another. But the event will affect the services themselves. And we heard lots of stories of that. So we need to be prepared for these increasingly frequent extreme weather events, whether they be bushfires, floods, cyclones, whatever they might be, because these will affect our health services. But we've also heard that, in actual fact, we need to be looking at the longer term changes in patterns of illness. And that's what is shown here. This is what we're going to be seeing increasingly frequently. These aren't broken legs and one thing and another. These are the different sorts of conditions that are going to increasingly present to us in emergency departments, in GPs' rooms, in specialist rooms, and in community health centres and so on. There are two broad ways that we can, sorry, I missed one out. The other point I want to make is, in passing, that health services are here to help people stay healthy and manage illnesses. But in actual fact, the way we deliver health services at present is making people sick by virtue of increasing climate change. Health services have a carbon footprint, depending on where we are in the world, but roughly 5 to 10% of a whole nation's greenhouse gas emissions come from health services. 5 to 10%. It's about 5 in Australia. We are pumping greenhouse gases into the atmosphere, creating climate change, creating all those problems. We need to move to a low carbon models of delivering health services in hospitals and in general practice and in the community. And again, there's lots of literature out there. There are 2 broad strategies for tackling climate change. You probably know this. There's mitigation, which is about bringing down very, very quickly, I'll come back to this at the end, bringing down very, very quickly how much greenhouse gases we emit into the atmosphere, principally from fossil fuels and the generation of energy, whether that be electricity or motor vehicles or aeroplanes, boats and so on. So dramatically reducing our emissions of greenhouse gases. And the other, again, we've heard lots about this in relation to bushfires and COVID, is getting ready for the inevitable effects, because they are coming. Don't bother hoping they're not going to come. They are coming. The good news about those 2 strategies is that there's loads of co-benefits. There's co-benefits for people's health as they perhaps take more physical activity and use the car less. They use public transport more. That brings benefits from physical activity. They eat healthier diets. They don't eat meat. They eat less dairy, eat more vegetables. There are loads of benefits that can be obtained. We might even, in fact, we almost certainly will, deliver better health care. Again, I haven't got time. I just want to highlight that there are things health services can do, and by that I'm thinking about things like the public health network, the primary health network here. I've had a look at the plan that's been developed. It's fantastic. I particularly like the emphasis on working with the community, working with other groups in the community, not just looking at health services. And I like the fact that it's not just about knowledge, it's about helping people develop skills. Very, very important. These slides will be available afterwards if you want. So it's about the health services. There are resources there. The Climate and Health Alliance with other groups developed a framework for a national strategy on climate, health and well-being for Australia a few years ago. Got 7 policy areas to do with promoting health, to do with research, education and capacity, leadership and government, research. And there are plans out there. There's a group called Global Green and Healthy Hospitals that the Climate and Health Alliance is the Australian agent for, so to speak. And this broadens it beyond just climate change, looks at how we can provide better, more sustainable health services. We're looking at food, pharmaceuticals, buildings, all sorts of things. All I'm saying is there are resources out there. There's what you can do at work. Again, those resources are there for you. Basically, it's about getting active, starting doing things, discussing it with your patients, thinking when you make a clinical decision, is this environmentally sustainable or not? About being a pain in the neck with your colleagues. And then there's what you can do in your personal life. Doctors, nurses, other health professionals, we're very trusted people in the community. We can join other groups and lend our expertise. We can measure our personal footprint. We can make sure our money isn't being used to create harm. Where's our superannuation invested? Do we bank with a bank that's environmentally responsible? Donate money, demonstrate. Write to your MP, go and speak to your MP, become a pain in the arse. Now, I want to finish with the really bad news, okay? The good news that you're going to be told all the time is how well we're doing. Okay, we've got the Paris Agreement signed in 2015 to keep temperatures below 2 degrees C by 2100. First of all, 2 degrees C is not safe. It's far from safe. 1.5 is probably the maximum we want to get to, and we're probably beyond that now if we measured it properly. Okay? We hear about the rollout of renewable energy. Now, there's no doubt that renewable energy is rolling out rapidly. This shows the uptake of wind and solar since 1971 to 2018, and you can see it is in the expression exponential. It's shooting up. Great news. Yes, we're really there. Just keep doing that, and we'll have 100% renewable energy in no time. What a load of crap. That graph is the one that is in the inset. Okay? If I can get this to work. Can I get this to work? That graph is this graph. And that line is this thin red line here. Because you can go into this website and it's interactive and you can take out all these others and just plot any one of them. And that is that thin red line. And in 2018, wind and solar made up 2% of the world's energy supply. Fossil fuels were still constituted 82%. Okay? We're nowhere near 100% renewable energy. What do we need to do? We need to start rapidly reducing our carbon and other greenhouse gas emissions. If we'd started in 1990, when this problem was first really seriously tackled, beginning to be thought about and discussed, we would only have needed to reduce it at a fraction of a % a year. If we'd started in 2010, we would have needed to have reduced greenhouse gas emissions at 3% a year. If we started today, we have to reduce them at 7.6% a year. They're still going up. Certainly until COVID struck, we've not started to go down yet. And if we delay anything for another 5 years, just as far back as the Paris Agreement, we have to reduce them at 15% a year. There isn't a hope in hell of that happening. That's why I say we're on the route to an environmental disaster. All we can really do is reduce the impacts and prepare for it. And that's what's important, and we've got to do it now, starting now, and we've got to start focusing on 2025 and 2030, not 2050, not 2100, which the politicians talk about, oh, blah-de-blah-de-blah. We've got 10 years. If we haven't turned this boat around in 10 years, it's going to be an absolute Armageddon later this century. And if you don't believe me, then look at this. What is this? Let me read it. I'll have to read it. I can't see it up there. They, never mind, have laid bare the unvarnished truth about the desperate situation humans and our planet are in, painting a disturbing picture of the real possibility that human life on Earth may be on the way to extinction in the most horrible way. So what climate catastrophist said this? You know, was this some wild greenie? Was this Bill McKibben? Was this David Attenborough? Who was this? Well, there we go. Sorry, it was Chris Barry, ex-Chief of Australian Defence Force, well-known radical communist. Thank you.
And this is the right moment for me to launch, and it gives me great pleasure to launch, the Sydney North Health Network's Climate and Health Strategy 2020. So I agree with Peter, truly fantastic that you're getting together on this, that you've got a strategy, and each brick is important in building this up to a significant enterprise, and that is great. So it gives me great pleasure to launch the strategy. Congratulations to everybody involved. The next step is action, not just having it down there on paper. It's doing something about it, as Peter would say. But this is not important. Peter, question for you. Why does it take a disaster for something to happen?
Oh, sorry, I hadn't seen that. Oh, Norman, you probably know that better than me. I mean, people say it's the way we've developed as humans, that, you know, we We very much focus on the short term. We'd like the status quo to continue. We find it very difficult to change. And it's only when there is some disaster that people really begin to think twice about things sometimes. But even then, people say, oh, it's all going to be different, it's all going to be different in future, and make a few changes often. But in actual fact, in no time at all, things have pretty much just sort of drifted back the way they were beforehand. But there's no doubt, you know, a disaster is an opportunity for change. And this is one, COVID, that needs to be grasped. And as I said earlier, because it's very much caused by the same issues as COVID that you outlined.
So, but one of the problems, Peter, is that when prevention works, nothing happens. So therefore, people, oh, we were predicted, you know, Paul Ehrlich was telling us there was going to be a population crisis, et cetera, et cetera. It never happened, therefore it's all bullshit.
That's when you work in public health, you get used to that. You know, your success is when nothing happens. And I got to say, in New South Wales, whilst, you know, it would have been fantastic if New South Wales Health had provided more money for public health over the last 20 years and health promotion and so on. But the reality is New South Wales is probably the best resourced, the best organised public health service in Australia. And when I talk to my colleagues in other states like Victoria, Western Australia, Queensland, Tasmania recently, South Australia, they've all had public health and community health services that have been torn apart at some point in the last few years. I've got to give some credit to New South Wales. So it's difficult to do that, really. But nonetheless.
Well, we just need to remember that in the 2009 flu pandemic, Victoria gave up. They stopped testing, they couldn't do it, and they didn't learn from it. Question for you, Sue, from online, which is, what's the approach in residential aged care during a pandemic? People will pass away from non-COVID causes. This is getting to the, people's right to make decisions about their end of life.
So it goes on to say, I would like to see those in residential aged care ask whether they would like to be locked down, seeing no one for weeks or months. And actually that was on one of the slides that didn't get up, was what happened to those people in lockdown. And it was entirely unnecessary. A number of organisations kept their facilities open. And I can tell you the tale of two mothers. My mother is in a facility that stayed open, and I could visit her, other than the 3 weeks Kerry Chant told us not to. I could visit her between 10 and 4, 7 days a week. I was temperature tested, asked the questions, did I have shown my flu vax, and had I been into any hotspots. But I could visit her every day. My mother-in-law is in another aged care facility in northern Sydney, in Lane Cove, and nobody was allowed to see her. Her husband of 67 years could talk to her on the telephone, and she's deaf, so there was no point, really. It was absolutely appalling, and it was only by multiple complaints to the Aged Care Quality and Safety Commission that we actually got the ability for him to talk to her through the fence. It was absolutely appalling. The guidelines from Commonwealth Government were that we should be allowing people in, and I totally agree with Wendy, who put that in, that we should be asking people what they want. It is hard because the organisations all said, oh, no, we want to protect our residents. That's absolute crap. They did not want to spend the money on the extra staff members to check people in and out, because where my mother was, you had to pay. They paid an extra staff member to be the concierge. The other thing the organisation where my mother is have done is train a whole lot of residents up to be what they're calling partners in care. We've all done the PPE training. We've all had practice on the ground. Fortunately, we haven't had to use it yet. So if they do get some COVID cases, we can still go in and help. Now, that's real, I think, compassionate. We were talking, Stephen Kinswell, compassionate aged care. And I think we really have to push for that. I've just been appalled, and, I've seen a lot in my Royal Commission role that we know about. But we are working on making that a lot better. GPs have a big role to play. I think they were completely sidelined unfortunately. People did die of loneliness, absolutely. People lost weight, they got pressure areas because there was no one there to walk them or feed them. It was a really appalling situation. Maybe we did avoid some COVID, but people were absolutely not happy. Sorry, that's my hobby horse, and that wasn't a Dorothy Dixer.
So we've got time for one or two questions to go. So just put up your hand and we'll get a microphone to you. There's one over here, person over here, just there. A question while we're getting there, a question online. Since SARS-2 is mutating so quickly, has the Oxford vaccine already become redundant since it's based on the spikes which change with each new strain? Good question, and the answer is it has changed. Worker at the Doherty was worried about this, and it seems that the vaccines produce enough of a breadth of neutralizing antibody and T-cell response that it's okay at the moment, but that may not be. So the important here is that you get a mass immunization campaign incredibly quickly so that the vaccine doesn't mutate around the vaccine, and that's the risk that we take. Yes?
My question was, we are doing very well, as we all know, in this country with compared to other countries. And I wanted to find out, how do you convince the people in Australia who have lost relatives during this, to convince them that we are doing very well? A lot of people will say that, or rather, I don't know why it happened and how it happened.
Right. Well, that's what I try and do. You know, tune into CoronaCast. That's what I'm trying to do all the time. But it's very hard when you've got relatives overseas in countries which have got vast numbers of cases. And you know, but when people talk, they realise just how hard life is in those other countries and how much easier it is here. We're very lucky, and it's tough. It's really tough. Another question online from Michelle Ferris. What education and practices can we provide living with dementia, their carers and friends, to better support their needs in an ever-changing health environment? Sue?
Thanks, Michelle. Oh, she's online, is she? I can't throw something at her.
There's a Nobel Prize if you know the answer to it.
Yeah, well, that's right. It's I think it's just being there, being caring, being, contacting them. We've done a lot with getting people to remember telephones. Older people actually can use telephones quite well. What interests me is younger people can't. My grandchildren wouldn't know what a dial or even a press button phone was, and they love playing with, one of our old landline phones. But we have found getting people to ring each other, letters, writing letters, that's come back in, and of course Australia Post has totally dropped the ball on that one, so it takes 2 weeks for a letter to go across Hornsby.
But it does arrive with a Cartier watch.
I wish. So it's that staying in contact. It's showing people you still care. I think that's really important. Sorry, Michelle, I'd love to say more than that. There's lots of things we could be doing, but lockdowns really has stuffed things up. But yeah, you do what you can. You show that you still care is the most important thing.
Yes.
Thank you, everyone. That was a terrific presentation. And the message of coming together and supporting compassionate communities is a well-tried and sustainable public health response, as we've heard. And community resilience has, as Yvonne told us, contributed to First Nations thriving over 60,000 years in this country. What have we learnt from First Nations knowledges about navigating change? And should we listen more attentively to their knowledge?
I'll just put my bit in about listening to the elders, and I think that's a real strength in Aboriginal communities, is that passing of knowledge down. I've certainly seen it down the South Coast where there's quite a strong Aboriginal community. The Yuin people are those other people around Bateman's Bay and Maria, and there is still real respect for the elders and how they would deal with problems. I didn't get to ask them how they would deal with COVID. I certainly learnt about the bushfires and where they would go and the caves they would go to on the river. It was really quite interesting.
And the message here is that Aboriginal communities took control of COVID, and there's been no spread in any Aboriginal communities, which has been a fantastic result, and that's taught us all a lesson. There's a comment I'll just take from Rebecca Walker, which is there should be incentives for healthcare businesses to recycle waste. Sorry, Penny, did you want to say something?
Sorry, I was just going to add, there has been, in the previous pandemic in 2009, there was a group up in the north of Australia that isolated, and the paper's been written on that, and they came together beautifully and worked together as a community. And that's been the basis for some of the other communities getting organised this time. And I know we, in New South Wales level, we have a disaster committee, and we were working with the AHMRC and developing their pandemic planning before the pandemic hit. So there's been a lot of planning done in that group. Obviously not enough, but they are a very organised, very resilient community.
Jane Fleming, that'll be the last question, unfortunately.
Okay. I'm just wondering, when you look at what happened with COVID, it seems to have short-circuited a lot of decision-making pathways, so we've been able to act more quickly than usual. Is there been anything going on that's been able to cement those pathways, those new, quick, I guess almost divergent pathways to what we had been going through previously, to make sure that those very quick decisions and that sense of urgency will be sustainable?
Do you want to pick that up, Penny?
During COVID, there were a lot of changes made my understanding is a lot of changes were made at the Commonwealth level. We had Michael Kidd come in, and he was amazing, and he pulled together the idea of the respiratory clinics very quickly and had that happen, and he did a number of GP roundtables. So there are more GPs now in that Commonwealth department than there have been previously. They brought back in people with memory from the 2009 one, so some of the GPs that have been working with Chris Bagley came back in. So they brought back that old knowledge, and they pulled together things very, very quickly. And at the state level, they also did a lot of things. There were a number of changes made. So there were some changes made in the emergency structure system, and that was what I was involved in today. I don't know, they're changing as we go, and I don't know what the future will be, but I think this has shown everybody that you can adapt really, really quickly, and so hopefully those lessons will be learned. But there were a lot of changes made that previously didn't exist, a lot of changes in structures and systems.
Could you please join me in thanking our fantastic speakers and panel? And I'd also like to thank our platinum sponsors, AbbVie and Amgen. And here are two videos from them. Thank you.
Osteoporosis is more common than breast and cervical cancer combined.
Weak bones mean a fall could cause a break.
You may lose your mobility.
Osteoporosis can be treated.
You already get pap smears and mammograms.
Ask your doctor about a bone density scan.
Your doctor wants to hear from you, so ask about a bone density scan today and say no to the big O.
Osteoporosis is
with hepatitis C when I had a general health check when I was around 19, 20 years old. And at the time I didn't know anything about hepatitis C, nothing at all. The GP basically said, oh, you've got hep C, and left it at that. I did feel the stigma of living with hepatitis C, and I'd learnt the hard way not to disclose it because I knew people were very, very fearful that they would get hepatitis C. So when I got onto the treatment, it was short, and I felt well, and I was very lucky to be cured at the end. I can't begin to explain the freeness that I felt around not being contagious. Like I felt like a normal person again. I would really encourage other people to get treatment for hepatitis C if they know that they're living with hep C. I wouldn't have known if I hadn't just had to have a doctor who tested for it. The sooner people get treated, the less likely they're going to have any complication. For me, it was very simple. It was just pills, and was lucky enough to be one of the majority that are cured.
Thank you again to Avi and Amgen. And can I thank you all very much for coming and coming to the AGM and coming to this event. Thank all those who were patient with us online and go safely. Thank you very much indeed.